Welcome to Pathagonia. This is Jay. Today we are going to talk about soft tissue tumors using Kurt's notes. Before we begin, huge shout out to Dr. Schaberg for compiling this very extensive list of soft tissue tumors. Let's begin with adipocytic. Lipoma, you may know a family member who's had these. These are benign adipocytic tumors composed of mature white fat, usually superficial subcutaneous. They're hard to distinguish from normal fat histologically, so you can sign this out as mature adipose tissue compatible with lipoma. There are specific types of lipomas. There's angiolipomas. These are usually tender on the forearm, tender because you have these fibrin thrombi within the vessels. Spindle cell lipoma, you have adipocytes and bland spindle cells with a variable myxoid background. You have this quote-unquote ropey collagen. It can be fat poor. So these arise usually in older men in a cape-like distribution, the neck, shoulder, back. You can see spindle and floret cells that stain with CD34. This is one of 3 soft tissue tumors that have retinoblastoma loss. This spindle cell lipoma, cellular angiofibroma, and myofibroblastima, particularly in the breast. Pleomorphic lipoma, you'll see it's on the spectrum of spindle cell lipoma, and the difference is you'll see these scattered bizarre giant cells that have these floret-like arrangements of multiple hyperchromatic nuclei. So your differential, at least for me, is I always get confused with pleomorphic lipoma and atypical lipomatous tumor / well-differentiated liposarcoma. But pleomorphic lipomas shouldn't have the MDM2 amplification. So when in doubt, you can always send for FISH. Plus, the well-differentiated liposarc / atypical lipomatous tumor should have more fibrous septae with atypical cells that do not look floret-like. Chondroid lipoma you have adipocytes with round cells and a mixal chondroid background. Neurofibrolipoma, adipocytes with fibrous tissue growing in nerves, usually in arms. Myelolipoma, you'll see bone marrow elements with fat. These are most common in adrenal medulla. I remember having that on a quiz, and I was really confused because I never knew what it was at that time. But if you see bone marrow elements in the adrenal glands, think myelolipoma. Lipoblastoma, this occurs in infants and resembles fetal adipose tissue. You'll have lobules of immature fat cells separated by tissue septae with a loose myxoid appearance. Myelolipoma, you'll have adipose tissue and smooth muscle bundles. And then hibernoma, I really like this entity histologically. You'll have these like brown fat cells that you can see them because they have these multiple small vacuoles within polygonal cells with distinct cell membranes. All right, I've alluded to atypical lipomatous tumor and well-differentiated liposarc. This is the most common adult sarcoma, usually in the elderly. It is non-metastasizing, but can recur or grow. So we use the term atypical lipomatous tumor and well-differentiated liposarc. Why is it so long? Well, it's because this tumor is in the extremities, we'll call it atypical lipomatous tumor because it's easier to resect. But if it's in the retroperitoneum, we'll use well-differentiated liposarc. So it's the same entity, but just location-wise, they are different. Histologically, they'll have variable amounts of lipoblasts, which are cytoplasmic, lipid-rich droplets with a hyperchromatic scalloped nucleus, as you can see here. There are subtypes of atypical lipomatous tumor / well-differentiated liposarcoma. It can be lipoma-like, resembling mature fat. It can be sclerotic. You'll have fibrous areas with scattered hyperchromatic atypical cells, as you can see here, or inflammatory with a brisk inflammatory infiltrate. As alluded to before, molecularly, if you're unsure if this is an atypical lipomatous tumor / well-differentiated liposarcoma, you could do molecular studies and you'll see ring chromosomes, and they should have an MDM2 CDK4 amplification. And if your institution has, you can have an MDM2 CDK4 IHC. Of note, P16 is a sensitive but not specific marker, as it's downstream from CDK4, so it is overexpressed. And it can de-differentiate. And it's important to know you don't need to fish classic cases of atypical lipomatous tumor / well-differentiated liposarc if you're already suspecting it based on histology. If you're not sure, here are some criteria, soft criteria that can help you out when to send out for fish. When you see equivocal cytologic atypia, when you see recurrent lipomas, when you see deep lipomas without atypia that exceed 15 centimeters, and when you have retroperitoneal or intra-abdominal lipomatous tumors lacking cytologic atypia. Okay, when you have a very pleomorphic type of soft tissue tumor, one of your differentials includes de-differentiated liposarcoma. The way you differentiate that from other entities like undifferentiated pleomorphic sarcoma is it should contain an atypical lipomatous tumor, a well-differentiated liposarcoma component. And then you'll see an abrupt transition to another component, which can be fibrosarcoma or lower grade sarcoma. Some do say de-differentiated areas should have a mitotic count of at least 5 mitotic figures per 10 high power fields. Molecularly, you can also kind of identify de-differentiated liposarcoma because they should have the same 12q amplification, the MDM2 amplification, as you see in just regular atypical lipomatous tumor, well-differentiated liposarcoma. It does have metastatic potential, in addition to being more locally aggressive. Okay, Myxoid liposarcoma. These are usually younger and on the lower kind of deep extremities. It resembles developing fat. You'll have multinodular proliferation of round cells with abundant myxoid matrix and this telltale chicken wire vasculature with multivacuolar and univacuolar lipoblasts, as you can see here. As you get higher grade, you lose the myxoid component and it's more cellular, composed of these round cells. And so that's round cell liposarcoma / high-grade myxoid liposarcoma. Molecularly, you can do a FUS-DDIT3 fusion to identify this. Pleomorphic liposarcoma. This is the least common liposarcoma. It's essentially an undifferentiated pleomorphic sarcoma, but it's called a pleomorphic liposarcoma because there's an area of differentiation with these scattered lipoblasts. So you know it arises from the adipocytic line of differentiation. There's extreme pleomorphism, including bizarre giant cells, as you can see here. They're malignant with frequent mets, and they have complex chromosomal rearrangements. So let's talk about fibroblastic, myofibroblastic tumors. Nodular fasciitis, or before I begin, for myofibroblastic and smooth muscle, sometimes they can be hard to distinguish. So if you get an SMA, it'll be kind of diffuse cytoplasmic for smooth muscle, but for myofibroblastic, you'll have this tram track-like pattern. Okay, let's begin with nodular fasciitis. The classical vignette is this rapidly growing subcutaneous mass that self-regresses. It's often in kids or young adults near the head and neck or upper extremities. Sometimes it can be misdiagnosed as a sarcoma because of the rapid growth and mitotic activity. Although it was initially thought to be reactive, there is a molecular characterization of nodular fasciitis. It's the USP6 MyH9 gene fusion. So histologically, you'll see tissue culture-like pattern. You can see extravasated red blood cells, pale nuclei with prominent nucleoli, and you'll see this torn stroma resembling S and C shapes. IHC, you can get an actin, and Desmond should be negative. And Their variants include ossifying fasciitis with metaplastic bone, cranial fasciitis, which is on the scalp of infants, and intravascular fasciitis in vessels. Proliferative fasciitis myositis, these are benign. They arise in the subcutaneous soft tissue of adults, usually on the arm. It's like nodular fasciitis with this tissue culture-like appearance, but you'll have these large basophilic ganglion-like cells with one or two vesicular nuclei and prominent nucleoli. It kind of remind me of Reed-Sternberg cells, but that kind of key point is that's more specific, or that kind of buzzword is for myxo-inflammatory fibroblastic sarcoma. So if some staff tells you, oh, there's Reed-Sternberg-like cells in this soft tissue tumor, they're probably going to hint at myxo-inflammatory fibroblastic sarcoma. IHC is similar to nodular fasciitis, and these are not true ganglion cells, as evidenced by if you get an S100, it will be negative. If it's in the muscle, use proliferative myositis. Ischemic fasciitis, this is pseudosarcomatous / benign reactive proliferation overlying the bony prominences of elderly and or immobile patients. It's often in the shoulder or sacral sites, and you'll have intermittent ischemia with breakdown regenerative changes. You'll see the zonal growth with central necrosis surrounded by proliferating blood vessels and fibroblasts, myofibroblasts. You can see scattered hyperchromatic atypical cells and mitoses, but no atypical mites. Elastofibroma. These are usually under the scapula of elderly patients. It's benign, likely reactive or a degenerative pseudotumor. You'll see these eosinophilic collagen and elastin. You can see occasional fibroblasts, myxoid material, and fat. And the elastic fibers have this degenerative beaded appearance. And you can highlight the elastin with an EVG stain. Nuchal type fibroma. This is benign, classically located in the posterior neck of adults. It's painless mass. It's almost acellular, densely collagenized with rare fibroblasts. It has a somewhat ill-defined entraps adjacent structures. And then IHC, it will be positive for CD34 and CD99 and negative for actin. Gardner-associated fibroma. These are benign and usually in the back of younger patients. There's a strong association with familial adenomatous polyposis and desmoid tumors. And you'll have this histologic overlap with nuchal type fibroma just mentioned before. For instance, it's densely collagenized with sparse spindled cells. You can have interspersed lobules of fat, and it can entrap other structures at the periphery. The spindle cells are usually CD34 and CD99 positive, and also often nuclear beta-catenin like desmoids, which we will talk about later on. Fibrous hamartoma of infancy. This usually occurs during the first 2 years of life. It's a benign superficial fibrous lesion, and there's 3 components in this organoid growth pattern. Number 1, as you can see here, you'll see these intersecting bands of mature fibrous tissue. It has these spindle-shaped myofibroblasts and fibroblasts. 2, you'll have nests of immature round ovoid or spindle cells within the loose stroma. And 3, you'll have interspersed mature fat. Molecularly, you'll have an EGFR exon 20 insertion duplication. Fibroma of tendon sheath. This is benign, slowly growing mass on the tendon sheath or aponeurosis, usually in adults under 2 centimeters and on extremities, often hand. It's well circumscribed, lobulated, and at least clinically, your differential would be tenosynovial giant cell tumor. But histologically, you would see giant cells, hemosiderin, and mixed inflammatory cells in the tenosynovial giant cell tumor. Going back to fibroma of tendon sheath, though, histologically, it's mostly hypocellular spindle cells and densely collagenized stroma, and you'll have these characteristic cleft-like areas, possibly vascular, and IHC will be variable actin and CD68. Calcifying aponeurotic fibroma. Say that 100 times quickly, backwards, with one foot. I'm just joking. Calcifying aponeurotic fibroma. It's benign. It's primarily in children. It can recur. Clinically, it's this slow-growing, painless mass on hands or feet attached to the aponeurosis, tendons, or fascia. Histologically, you'll see variable cellularity throughout the lesion. You have these plump, bland fibroblasts with dense collagen. But your key point is you'll see distinct areas of coarse calcifications and cartilage formation, and it can have this infiltrated growth. Molecularly, it has an FN1 EGF fusion. Fibromatosis, we alluded to this when we talked about Gardner type fibroma or Gardner associated fibroma. This is benign, never metastasized. However, this is infiltrative with strong tendency to recur locally. There's two major divisions. Superficial, you'll have your palmar, plantar, penile, small, slowly growing. Penile, it'll be known as Peyronie's disease. Plantar, I think it's Lederhosen, and palmar, I forget what palmar the clinical term is, but it's typically seen in kind of the Scandinavian countries in men, older men. Okay, deep desmoid type, abdominal, mesenteric. It's more aggressive and it has a high recurrence rate, greater than 50%. It involves the deep structures. And interestingly, even if you have microscopic or if you have positive margins on your excision, that does not predict recurrence. It has infiltrative growth into surrounding structures like skeletal muscle, broad sweeping fascicles, and you'll have these uniform spindled cells with small, pale nuclei with pinpoint nucleoli, moderate amounts of collagen, surrounding cells, and slightly myxoid background. Your way to diagnose this, to help you diagnose this, is you get a beta-catenin, and it should stain aberrantly nuclear. And it's also important to note, if you have a patient you sign out as having deep fibromatosis or desmoid type, it can be associated with familial adenomatous polyposis. Again, that's in chromosome 5q21, 22, and mutations in the APC beta-catenin pathway. Inflammatory myofibroblastic tumor. This is a borderline malignancy. The most common sites are lung, mesentery, omentum, but you can get them elsewhere too, like in the uterus. You'll have histologically bland spindled to stellate cells and myxoid to hyalinized stroma. They can have this loose fascicular or storiform growth, but you want to look out for this prominent lymphoplasmacytic infiltrate within the soft tissue. The most cells are bland, but sometimes you might have these large cells with prominent nucleoli. If you're unsure, you can order an ALK and it can be positive. However, it's very important to note that even if ALK is negative, you can still have an IMT or inflammatory myofibroblastic tumor, as only 50% or so are positive for ALK. Fibrosarcoma, it's almost defined out of existence, as mentioned by Dr. Richard Kempson, because many tumors that were previously called fibrosarcoma have been reclassified as synovial sarcoma, which has an X18 SYT SSX1 translocation, undifferentiated pleomorphic sarcoma, fibromatosis, or malignant peripheral nerve sheath tumor. You'll have this classically you'll have this herringbone pattern, and this is what is meant by this herringbone pattern. There's no specific IC or molecular. It's important to note that if you have a dermatofibroma sarcoma protuberance, which should be CD34 positive as opposed to dermatofibroma, your DFSP can undergo fibrosarcomatous transformation. It loses that storiform pattern and CD34 to become herringbone. Infantile fibrosarcoma. So the classic vignette is, or the classic presentation is, you'll have these newborns or infants, and you'll have this tumor on the extremities rapidly growing, This is malignant. And histologically, you'll see sheets of tightly packed spindled cells with herringbone appearance, little pleomorphism, often lymphocytic infiltrate. And if you're unsure, you can send for molecular, and it'll have this 1215 ETV6 and TREC3 fusion. Also seen in this fusion, 1215 is seen in cellular mesoblastic nephroma as well. So myxofibrosarcoma, of note, the old name was myxoid malignant fibrous histiocytoma. So if you go to your slide library and blow out the dust and it says myxoid malignant fibrous histiocytoma, just know that's myxofibrosarcoma. This is malignant. It's a slow-growing mass on the extremities of the elderly, and it has this multinodular growth. The telltale histology is a myxoid background with varying cellularity, usually low. You'll have these curvy linear vessels that have tumor cells attached that look like kind of melting wax. And then you'll see these stellate spindled cells with hyperchromatic pleomorphic nuclei with indistinct pink cytoplasm. IC has focal actin, but molecularly there's no telltale defining molecular study. It has a complex karyotype. Now, I personally have been getting confused with myxofibrosarcoma and low-grade fibromyxoid sarcoma because they sound similar, and this one starts with myxo, so it has more myxoid components, and fibromyxoid just has more fibrous components. And more importantly, kind of just like, or as importantly, demographic-wise, myxofibrosarcoma is seen in elderly individuals. Low-grade fibromyxoid sarcoma is seen in young to middle-aged adults. So you'll have these varying fibrous and myxoid areas, mostly fibrous though. It's important to know if you see curvy linear vessels that can be seen in low-grade fibromyxoid sarcoma as well as myxofibrosarcoma. And you can have large collagenous rosettes, and you'll see these bland spindle cells with small hyperchromatic nuclei. Fortunately, this, compared to myxofibrosarcoma, has a telltale molecular test you can do. You can do a FUS-CREB3L2. You can do a FUS-FISH for this. And then IHC-wise, you can get a MUC4, which should be positive, and often EMA positive as well. Sclerosing epithelioid fibrosarcoma. This is malignant. This is deep soft tissue of limbs. Your differentials include invasive lobular if they're female. And this is also MUC4 positive and often EMA positive, and it's thought to be kind of like a spectrum to low-grade fibromyxoid sarcoma. And you'll see this densely hyalinized stroma with epithelioid cells arranged in cords and nests, and cells have scant, clear cytoplasm and angulated nuclei. So molecularly, it's somewhat diverse, but many cases have FUS or EWSR1 and CREB fusion, and it's thought to be a spectrum to low-grade fibromyxoid sarcoma. All right, just to review, before we go to nerve sheath tumors, we talked about adipocytic tumors, lipomas. You can have specific types of lipomas. We talked about atypical lipomatous tumors, well-differentiated liposarcoma. This has an MDM2 or CDK4 amplification at 12q. These can undergo dedifferentiated liposarcoma. Myxoid liposarcoma, we talked about the 1216 FUS DDIT3, and if there's less myxoid and more kind of cellular areas with round cells, it's higher grade. Pleomorphic liposarcoma, it's like a undifferentiated pleomorphic sarcoma, but has scattered lipoblast. Fibroblastic, myofibroblastic tumors, you have your nodular fasciitis. It has that USP6 gene fusion. Proliferative fasciitis, it's like nodular fasciitis, but it has these basophilic ganglion-like cells, but they're not true ganglion cells. We talked about ischemic fasciitis. It has this pseudosarcomatous proliferation overlying bony prominences of elderly and or immobile patients. Elastofibroma, you'll have elastic fibers with a degenerative beaded appearance that you can see on EVG stain. Nuchal type fibroma, posterior neck of adults, almost acellular, densely collagenized on histology. Gardner associated fibroma, It also has histologic overlap with nuchal-type fibroma. It's associated with FAP and desmoid tumors. Fibrous hamartoma of infancy, you'll have this organoid growth pattern with intersecting bands of mature fibrous tissue, nests of immature round ovoid or spindle cells, and interspersed mature fat. Fibroma of tendon sheath, you'll have slow-growing mass on tendon that's hypocellular with spindled cells and cleft-like spaces. Calcifying aponeurotic fibroma, often in children, in the aponeuroses or tendons, you'll have areas of calcifications and cartilage formation. Fibromatoses, you can have superficial and deep. Deep generally have more nuclear beta-catenin positivity. Inflammatory myofibroblastic tumor, you'll have a prominent lymphoplasmacytic infiltrate with bland spindled cells, and approximately half are ALK positive. Fibrosarcoma, diagnosis of exclusion, it has that herringbone. Infantile fibrosarcoma, newborns, rapidly growing, it has that 1215 ETV6 NTRK3 fusion and has a lymphocytic infiltrate. Myxofibrosarcoma has these characteristic curvilinear vessels seen in older individuals and with more myxoid background. Low-grade fibromyxoid sarcoma has more fibrous. It's seen in younger individuals, has positivity for MUC4, and kind of on the spectrum of sclerosing epithelioid fibrosarcoma, which is also MUC4. It's these densely hyaline stroma with epithelioid cells arranged in cords and nests. Your differentials include invasive lobular, and so you want a pancytokeratin maybe to help differentiate that if you're unsure. And then let's talk about nerve sheath tumors. Schwannoma, these are benign, often associated with nerves, and very low risk of transformation, composed entirely of well-differentiated Schwann cells, and they're typically encapsulated, and you'll have these hypercellular areas known as Antony A, and more myxoid areas and hypocellular areas known as Antony B. Within Antony A, you'll have these palisading, and this unit right here with the palisaded cells, the acellular area, and then the nuclei right here, that's called a Verrier body. And you'll have hyalinized blood vessels and lymphoid aggregates are common. IHC will be strong diffuse S100 with scattered CD34 and moderate calretin. And subtypes include ancient change, which have degenerative atypia with large hyperchromatic nuclei but absent mites. Cellular, which is just exclusively Antony A, and melanotic, which contains melanosomes, so can stain with melanocytic markers, often epithelioid, and have a higher risk of transformation. Neurofibroma, these are benign, it's most commonly solitary and sporadic, but if you have multiple, then you want to, it's a hallmark of neurofibromatosis type 1, NF1. And the most common presentation is cutaneous, although it can be intraneural or diffuse. Plexiform neurofibroma, which kind of is akin to like a bag of worms on physical exam. It's almost exclusively in NF1 and has a higher risk of malignant transformation into malignant peripheral nerve sheath tumor. You'll see a mixture of Schwann cells, perineural-like cells, fibroblastic cells, and entrapped axons. You'll have randomly oriented spindle cells with wavy hyperchromatic nuclei. These are often hypocellular and variably myxoid. And the collagen strands kind of look like shredded carrot collagen. It'll also have diffuse S100 positive, but less so than your schwannoma, moderate CD34 positivity, and neurofilament shows entrapped axons within the lesion. It can be pigmented or show ancient chains as well as your schwannoma. Perineurioma is benign. It can be intraneural or soft tissue, sporadic, and you'll see these spindle cell proliferation with characteristic thin, delicate, bipolar processes, and they have a wavy tapering nuclei with perivascular whorls. If you're unsure, you can get an IHC and it'll be positive for EMA, Claudin 1, and GLUT1. Granular cell tumor, This is a benign neoplasm with neuroectodermal differentiation. You'll have these epithelioid to spindle cells with abundant eosinophilic granular cytoplasm, highlighted by your PAS diastase. It has a lot of lysosomes due to inactivating mutations in ATP6AP1. So that's why it has that granular appearance. Stains will be positive for S100, CD68, inhibin, calretinin, and there's a congenital and gingival granular cell tumor, also known as congenital epulis. Although it looks similar, S100 is negative and is located on the gingiva at birth. Ganglioneuroma. This is benign, usually in the posterior mediastinum or retroperitoneum. You'll have no immature neuroblastic elements, unlike your ganglioneuroblastoma. Although some likely represent mature neuroblastoma, it's thought that these are mostly arise de novo. You have mature ganglion cells in neuromatous stroma. And when multiple or diffuse, you want to think about it can be seen in MEN2B, Caldens, NF1, and you can have ganglioneuromatoses. So stain-wise, the Schwann cells will be S100 positive. Ganglion cells will be positive for synaptophysin and neurofilament. So I like to think of these just for my conceptual understanding as a spectrum where you have your ganglioneuroma. This is the most mature. Then you have your ganglioneuroblastoma, which is in between ganglioneuroma and neuroblastoma. So neuroblastoma, if it's more mature but still has immature elements, it's a ganglioneuroblastoma, and if it's completely mature, it's a ganglioneuroma. Traumatic or amputation neuroma, this is non-neoplastic nerve proliferation after trauma because the nerve is trying to reestablish connections. Histologically, what that looks like is haphazard proliferation of nerve fascicles, including axons and perineural cells. And the damaged nerve is often easily identified. MPNST. Malignant peripheral nerve sheath tumor. This is malignant, frequently in the setting of NF1, has a poor prognosis. It must arise from a peripheral nerve or pre-existing peripheral nerve sheath tumor. Has a variable appearance but can resemble undifferentiated pleomorphic sarcoma or fibrosarcoma. From low power, it has this marbling effect. You know, like in the meat, you can see the marbling of the fat. It kind of has that appearance because it has extensively cellular areas with less cellular areas. And then as you go more closely, you can see spindle cells arranged in sweeping fascicles and cytologically have this wavy, buckled nuclei. It has this geographic necrosis and mitotic activity, often greater than 10 per high power fields. It have patchy S100 and SOX10. There's loss of H3K27ME3 expression, which is associated with worse prognosis. It's not entirely specific because you can see these in subsets of melanomas as well. And subtypes include your malignant trident tumor, which is basically malignant peripheral nerve sheath tumor with rhabdomyoblastic differentiation. You can have MPNST with glandular differentiation, and you can have an epithelioid MPNST, which has polygonal epithelioid cells, usually unique, strong, diffuse S100 staining. And going back to your malignant trident tumor, here's your cells with rhabdomyoblastic differentiation. Here's a strap cell. Other nerve sheath tumors include nerve sheath myxoma, benign superficial myxoid. It has irregular, slow-growing nodules separated by fibrous bands containing spindle cells and myxoid matrix. It's S100 positive. Ectopic meningioma, essentially meningioma and soft tissue. You'll have your world architecture, and IHC will be EMA, PR, and SSTR2A positive. And PEN, or palisaded encapsulated neuroma. This is a benign dermal tumor, often on the head and neck. It's lobular with sharply demarcated borders and has axons, Schwann cells, and perineural fibroblasts. All right, are y'all still with me? Because we're we're getting fired up. We're a little less than halfway there, but we're going. So perivascular tumors, glomus tumors. I like to think of these as copy-pasted cells because they all look similar. These are benign. It's derived from the glomus body, which are specialized AV anastomosis regulating heat. You'll often have these in the fingers and toes, although they can oftentimes also be in the visceral area, like the stomach. It's often painful, and it has very rich vascular network separating tumor cell nests, and you'll have those kind of distinctive epithelioid copy-paste cells together. It will be actin positive, and if you have more vessels than cells, it can be called a glomangioma as well. Myopericytoma, myofibroma, these are benign and exist on a spectrum. Myofibroma are usually in the head and neck in the first year of life. It'll be multinodular, well circumscribed, and it has a biphasic appearance. You'll have immature appearing plump spindled cells with staghorn vessels, and then you'll have areas of more mature spindled cells in bundles and whorls. So you can have a myopericytoma, which is a superficial mass in adults. It's nodular, well circumscribed. You'll have a concentric multi-layered growth of spindle cells around vessels and very richly vascular. And IHC-wise, you'll have actin positive. PCOMA stands for, you probably heard of PCOMA if you are a pathology resident, and it stands for perivascular epithelioid cell tumor. It's benign, and often areas of epithelioid tumor cells with abundant granular eosinophilic to clear cytoplasm with round nuclei. It's associated with vessel walls and radial arrangements, and it expresses melanocytic markers like HMB45 and variable melin A. It's because on electron microscopy, you can see that they have pre-melanosomes. And then it's also positive for smooth muscles like actin, desmin. It's important to note that a subset of cases are associated with tuberous sclerosis, and you can see this in many sites and organs. And this family includes angiomyolipoma, clear cell sugar tumor, and lymphangioliomyomatosis. Now say that 100 times. And all these will also stain with melanocytic markers and smooth muscle. Speaking of smooth muscle, let's talk about smooth muscle tumors. So your IHC for smooth muscles include SMA, desmin, H-caldesmin, and calponin. Leiomyoma, you can see this in the dermis. It's derived from the pilar muscles and vessels, very uncommon in deep soft tissue. You'll have cytologically bland spindle cells with this cigar-shaped nuclei, fascicular architecture, and then what my staff like to call the nuclei, it has these glycogen snacks, like little vacuolizations around the nuclei. And there's no nuclear atypia, and at most very rare mitoses, less than 1 per 50 high power fields. You can have a pilar leiomyoma, which is an ill-defined dermal nodule composed of haphazardly arranged smooth muscle bundles, and the fascicles often dissect between the dermal collagen and oftentimes painful. And an angioleiomyoma, which is a well-circumscribed neoplasm composed of mature smooth muscle cells with prominent blood vessels within. Leiomyosarcoma. This is malignant, poor prognosis, oftentimes in the retroperitoneum of adults, and often arise from veins. It looks, from low power, similar appearance to leiomyoma with the fascicular architecture, but as you look closely, you'll have notable pleomorphism. You'll have mitotic activity, oftentimes with atypical mitoses and necrosis. Molecularly, you can have a complex karyotype. Just of note, you can have a leiomyosarcoma of the uterus too. And it's important to note that those exist as well. And you will also see mitotic activity and often atypical mites as well. EBV-associated smooth muscle tumor. These are benign, but patients can get multiple primaries. It's seen in the setting of immunodeficiency. You have HIV, post-transplant patients, and has mostly typical smooth muscle appearance with vesicular architecture and blunt-ended nuclei, and you can see tumor infiltrating lymphs and more round cell areas. But molecularly, you need to confirm that there's EBV in the tumor with an EBER in situ hybridization. Okay, skeletal muscle tumors. The most specific IHCs are myogenin and MYOD1. Also, this can stain positive with smooth muscle markers like desmin and actin. So, you know how the benign tumors of smooth muscle is a leiomyoma? Well, a benign tumor of skeletal muscle is a rhabdomyoma. It's benign, but the location can cause problems, especially in the heart. So your cardiac type rhabdomyoma occurs in infants and young children. You'll have large polygonal vacuolated cleared out cells, spider cells, and it's often in the setting of tuberous sclerosis. And then you can have your adult type rhabdomyoma, usually in the head and neck, often pharynx or tongue. You'll see this large polygonal cells with this abundant eosinophilic cytoplasm. You can see some spider cells, and it's unencapsulated and has a lobular growth. And then fetal type rhabdomyoma, also usually in the head and neck, any age. You'll have irregular bundles of immature skeletal muscle and a myxoid background. Embryonal rhabdomyosarcoma. This is malignant. It's the most common soft tissue sarcoma in kids. You can have a specific subtype in your adults, your pleomorphic rhabdomyosarcoma, usually in the head and neck, the nasal region, the tongue, or the GU region, like the bladder or prostate. And it resembles embryonic skeletal muscle cells. It'll be positive for myogenin or MYOD1. Some areas are hypercellular, small round blue cells, and other areas have maturing regions with rhabdoid cells. You can see tadpole cells and strap cells with cross striations set in a myxoid stroma. And then you can have your botryoid type, which is densely cellular layer below the epithelial surface, which is the cambium layer. And it's separated by hypocellular area, as you can see here. And it'll grow as a polypoid surface nodules, which is grape-like and usually projecting into mucosal lined spaces like the vagina or nasal cavity. So it's called a cambium layer because cambium is a part of a layer of the tree, and the epithelium is supposed to resemble the bark. You have that hypocellular area, and then you have that hypercellular region. Alveolar rhabdomyosarcoma. Oh, I'm sorry. I said before that embryonal rhabdomyosarcomas can arise in adults, but generally rhabdomyosarcoma, there's different subtypes: embryonal, alveolar, pleomorphic, spindle cell sclerosing, but the pleomorphic type can arise in adults. Okay, going back to alveolar rhabdomyosarcoma, this is malignant. It's more aggressive than your embryonal rhabdomyosarcoma. It's often in adolescents and young adults in the deep soft tissue of your extremities and sinuses. It's highly cellular and is part of that small round blue cell differential. It's often nest-like, hence the term alveolar. Despite the rhabdomyosarcoma name, it'll have absence of strap cells and tadpole cells, although it'll have a strong diffuse myogenin. Molecularly, this is defined by a FOXO1 fusion with either PAX3 or PAX7. And if that's the case, it has a worse prognosis than your embryonal rhabdomyosarcoma. If it doesn't have that fusion, then it's, some studies say, has the same prognosis as embryonal. Pleomorphic rhabdomyosarcoma, this is malignant, but more commonly in adults in the deep soft tissue. You'll have high-grade cytologic atypia and eosinophilic polygonal to tadpole-like cells, no embryonal or alveolar component, and resembles heterologous differentiation in your carcinosarcomas. Spindle cell rhabdomyosarcoma is malignant. It's likely a variant of embryonal. usually in the young boys, especially the peritesticular region, and it's exclusively spindled cells with cigar-shaped nuclei and has better prognosis than other rhabdomyosarcomas. And your sclerosing rhabdomyosarcoma is malignant, usually adults in soft tissue. You'll see nests of small round blue cells, and sometimes they can be in single file. You'll have abundantly hyalinized eosinophilic to basophilic matrix. MYOD1 is strongly positive, while myogenin and desmin are only focal. Fibrohistiocytic tumors. You have your tenosynovial giant cell tumor. These can be benign, but can be locally destructive. You'll see a mixture of bland mononuclear cells, foamy macrophages, hemosiderin-laden macrophages, and osteoclast-like giant cells. Mitoses are common, and molecularly they'll have the CSF1 gene rearrangements, and IHC mononuclear cells would be CD68, CD163 positive with scattered desmin. And you have two types. You can have your localized type, which is discrete, it's rounded, usually in the digits, it's less aggressive. And you have your diffuse type, which grows in expansive sheaths, often in or around the knee, often intra-articular, and it's also known as pigmented villonodular synovitis, and you need to treat this more aggressively. Fibrous histiocytoma. This is benign, generally, and it's neoplasm or neoplasm-like. Some think these occur after trauma. And you have fibroblastic and histiocytic cells arranged in short fascicles. So in derm pathland, these are called dermatofibroma. In the dermis, looks like a blue haze in the dermis from low power. They're grossly circumscribed, but microscopically have irregular, often jagged borders. As you look closer in your microscope, you'll see collagen trapping at the periphery. You'll see epithelial basilar induction with hyperpigmentation, meaning your epithelial component overlying the DF will become more hyperplastic, and it can mimic a BCC, especially the basilar region. And IHC, you'll have a factor 13A positivity, CD163 positivity, CD68 positivity, and CD34 will be negative. Your DFSP will be CD34 positive. If it's in the deep soft tissue, it's called a deep benign fibrous histiocytoma, although it's very rare. And then you can have your plexiform fibrohistiocytic tumor, plexiform architecture in the deep soft tissue dermis. It's important to know that when you think of DF or dermatofibroma, you want to rule out DFSP or dermatofibromasarcoma protuberance. DFSP, you'll have honeycombing of fat, and it'll look more monomorphic because that's driven by a 1722 molecular translocation. I think it's like COL1A1, PDGFR alpha. And then DFs will look more heterologous and more different appearing when you compare cells from another cell as opposed to your DFSP. Vascular tumors, endothelial cells stained with CD31, ERG, FLI1, often CD34. Sorry, I'm taking a little drink. So you can have your vascular malformations. These are developmental abnormalities that occur during embryogenesis in the utero that grow with the host, and they do not regress. Your AV malformations, histologically, you'll see large tortuous arteries with fragmented elastic lamina. You'll see thick-walled veins, most commonly in the head and neck and brain. Sometimes you'll get emboli material when they remove the AV malformation. And venous malformations, you'll have poorly circumscribed collection of abnormal veins. They vary in size and proportion. They're often abnormally thick or thin walls for size, and it includes your cavernous hemangiomas, which has a collection of large dilated veins with thin walls. You have your cutaneous capillovenous malformation. For instance, that's like telangiectasia, often diagnosed clinically, but it can be associated with a variety of conditions, including your Osler-Weber-Rendu. And then intramuscular hemangioma, small vessels within muscle, often parallel. Okay, Mason's tumor or papillary endothelial hyperplasia. I've gotten a lot of these during my sign-outs during SearchPath, and they can look a little bit freaky or bizarre. It'll be intravascular with exuberant proliferation of endothelial cells with fibrin. You'll see small papillae covered by a single layer of endothelium with a collagenized fibrin core. There won't be atypia or mites. It can mimic angiosarcoma, but how to distinguish them is papillary endothelial hyperplasia, or your Mason's tumor, is exclusively intravascular growth. It's your endothelial cells kind of recanalizing the fibrin thrombi, and you'll have lack of mites or atypia. Bacillary angiomatosis, this is a pseudoneoplastic vascular proliferation. It's caused by Bartonella, which is a gram-negative bacilli, which causes your cat scratch disease. Almost exclusively in immunocompromised adults, often AIDS. And you'll see this in the skin and soft tissue. Histologically, you'll have lobules of capillary-sized vessels with plump endothelium with clear cytoplasm. And as you look closer, you'll see this associated neutrophilic infiltrate. And to cinch this diagnosis, get your Wirth and Starry, which will highlight the organisms. Hemangiomas. These are benign vascular neoplasms. They often grow faster than the patient. And it's categorized by vessel size appearance. So your pyogenic granuloma or lobular capillary hemangioma. This will be polypoid exophytic on the skin and mucosal surfaces. It's unclear if it's truly neoplastic, and it has this lobular arrangement of small capillaries with larger feeder vessels. And you see a myxoid stroma with inflammatory cells. Your infantile juvenile hemangioma, it starts as a flat red mark soon after birth, and then it looks like a strawberry over several months. And it regresses over several years, and you'll see a multinodular mass fed by a single arteriole, and the appearance varies depending on the phase, where it's just a flat red mark, or if it looks like kind of like a strawberry over several months, or after it regresses. And if you're unsure, it has this unique expression of GLUT1. And then rarer subtypes include your hobnail hemangioma, anastomosing hemangioma, and spindle cell hemangioma. Epithelioid hemangioma, this was in the prior known as ALHE, or angiolymphoid hyperplasia with eosinophils. These are benign. They're often in young adults in the superficial head and neck, and it's circumscribed in the subcutis. You'll have lobules of capillaries centered around larger vessels. And as you look higher power, you'll see endothelial cells that are plump, kind of hobnailing, so to speak. And you'll have round nuclei and abundant eosinophilic cytoplasm. And it has associated inflammation rich in eosinophils. So here you can see the plump endothelial cells, and then the background inflammatory eosinophils. Lymphangioma, this is benign, often in kids during the first year of life. It's associated with Turner syndrome. And histologically, from low power, you'll see thin wall, dilated lymphatic vessels of different sizes, as you can see here. And it's lined by a flattened endothelium. It's frequently surrounded by lymphoid aggregates. Grossly, you can see milky lymphatic fluid. And the endothelium expresses D240 and PROX1, which are specific for lymphatics, and also CD31. Kaposiform hemangioendothelioma. This is a locally aggressive vascular tumor exclusively in children. It's often associated with this clinical picture of a Kasabach-Merritt phenomenon, where you have consumption of platelets that leads to thrombocytopenia. On low power, you'll see a cannonball fashion of soft tissue tumor, and as you look closely, you'll see tightly coiled glomeruloid-like areas. And you have different areas that have features of both capillary hemangioma and Kaposi sarcoma with the spindled cells. Here you see the capillary-like hemangioma, and then you can see those spindled cells. Epithelioid hemangioendothelioma. This is malignant but less aggressive than angiosarcoma. It's often in the soft tissue, often angiocentric, and has an expanding wall and obliterating the lumen. It's common in the liver, and histologically, from low power, you'll see cords of epithelioid endothelial cells in a myxohyaline stroma. And as you look closer on high power, you'll see these eosinophilic cells with vacuoles containing erythrocytes. These are known as your blister cells. The specific stain is CAMTA1, and molecularly you'll have this recurrent CAMTA1 WWTR1 fusion. Kaposi sarcoma. This is locally aggressive, often multiple cutaneous lesions caused by your HHV8 in all cases. It can be classic or endemic, which are usually indolent or associated with immunosuppression. Either you're immunosuppressed because of organ transplant or by HIV/AIDS. In that case, it's more aggressive. Histologically, you'll have a proliferation of bland spindled cells with slit-like vascular spaces containing erythrocytes, and is often associated inflammatory infiltrate and hyaline globules. Your differential is angiosarcoma, but your IHC should show HHV8 positivity in Kaposi's. Pseudomyogenic hemangioendothelioma. These are rarely metastasized. They often develop additional nodules in the same anatomic region, often in the young men on leg. And histologically, you'll see infiltrated sheets and fascicles of plump spindled cells. You'll have abundant, brightly eosinophilic cytoplasm resembling rhabdomyoblasts, hence the name pseudomyogenic hemangioendothelioma. You'll have vesicular nuclei, and IHC, it'll be positive for your pancytokeratin, positive for ERG, positive for FOSB, and plus or minus for CD31. INI1 will be intact, and molecularly, it'll have a SERPINE1 and FOSB gene fusion. Atypical vascular lesion, these are benign. They occur in irradiated skin, often of the breast. They're often small to multiple, and histologically, you'll have these irregularly shaped, thin-walled vessels with branching and anastomosing growth. It's lined by a single layer of endothelium with some hobnailing and hyperchromasia. There's no endothelial cell multilayering or true cytologic atypia. And IHC-wise, you'll have no MYC overexpression, in contrast to angiosarcoma that arises from breast radiation, which, let's talk about angiosarcoma. This is very aggressive, typically elderly. I like to think of these as arising in three different situations. One is your old person who has a lot of sun exposure on the scalp or head and neck. Number two is patient with breast cancer that has received radiation to that area. Number three is also a patient with breast cancer that had an axillary lymph dissection and has chronic lymphedema, or just any patient with chronic lymphedema. So you'll have varying degrees of vascular differentiation. Some areas show well-formed anastomosing vessels, while other areas have solid sheets of high-grade cells. It can be epithelioid or spindled, and often extensive hemorrhage. If it's epithelioid angiosarcoma, it can stain positivity with cytokeratin markers. And it's very, very aggressive. I heard around, one study I was reading says around 50% of people survive after 1 year. And then, unlike benign lesions, you'll have significant cytologic atypia. You'll have necrosis. You'll have endothelial cells piling up as opposed to your atypical vascular lesion and mitotic figures. Grade does not predict prognosis because all are aggressive. And for post-radiation angiosarcoma of the breast, this occurs around 5 years after radiation, if you do have this, and has a high level of amplification of MYC. Okay, tumors of uncertain differentiation. Are you still with me? Because we got this. Myxoma, this is benign in adults. Histologically, it has uniform cytologically bland small spindle to stellate cells and abundant myxoid stroma. Grossly, it can look like jelly, and it can show cystic changes and have more cellular regions. there should be no atypia or mites. Otherwise, you want to consider myxofibrosarcoma. Intramuscularly, you can have an intramuscular myxoma. It has a frequent gene S mutation. You want to think about your syndrome of Mazebrod, which has intramuscular myxoma and fibrous dysplasia. And then you can have a juxta-articular myxoma, which is around a large joint and lacks gene S mutation. This used to be favored to be called aggressive angiomyxoma, hence the quotes, but now now the term has changed to deep angiomyxoma because it's benign. It's not aggressive, or it's not malignant, and it does have frequent recurrences. And it's in adult women in pelvico-perineal regions. Histologically, you'll see these small spindle to stellate cells in a loosely collagenized myxoid stroma. You'll have scattered vessels of varying sizes and scant eosinophilic cytoplasm. You'll see larger spindled myoid cells congregate around larger vessels and nerves. IHC-wise, it'll be ERPR positive with variable desmin and actin, and molecularly, you'll have oftentimes an HMGA2 rearrangement. Extrarenal rhabdoid tumor. These are malignant, very aggressive in infants and children. You'll have these characteristic rhabdoid cells, these large, round, polygonal cells with abundant, eccentric, glassy, eosinophilic cytoplasmic inclusions and vesicular nuclei with prominent nucleoli. It's morphologically, genetically identical to your rhabdoid tumors in the kidney and brains of kids. So those also have this SMARCB1, INI1 loss and activation. And it'll be CAM5.2 positivity in the inclusions. Ossifying fibromyxoid tumor. It's usually benign with potential with recurrence. Histologically, on low power, you'll see lobules, and as you look, you'll see the circumscribed mass with peripheral zones of metaplastic bone. And on higher power, you'll have monomorphous rounds of spindle cells arranged in cords surrounded by fibromyxoid stroma. IHC-wise, it'll be positive for S100, plus or minus for desmin, and molecularly, you'll have a PHF1 rearrangement. Angiomatoid fibrous histiocytoma. This is indolent with a very rare recurrence, and most commonly in young patients. Low power, you'll see this pericapsular cuffing of lymphocytes, mimicking a lymph node. And then as you go higher power, you'll see nodules of spindled histiocytoid cells with syncytial growth, and you'll have these pseudoangiomatoid spaces full of blood and a thick fibrous capsule. Molecularly, you'll have an EWSR1 CREB1 fusion and variable desmin and EMA. Ectopic hamartomatous thymoma. This is benign, exclusively in the lower neck region, often adults. You know how some names can be confusing in pathology? Well, here's a case in point. Despite the name, there's no evidence of thymic origin or differentiation. You'll have haphazard blending of spindle cells, epithelial islands, and adipocytes. And some spindle cells show a lattice-like growth, and islands of often squamous epithelium blend with the spindle cells. The epithelium stains with keratin, and plump spindle cells express actin, and delicate spindle cells express CD34. Phosphaturic mesenchymal tumor. Most tumors are benign, but they can cause significant side effects because they produce FGF23, and this causes tumor-induced osteomalacia by inhibiting renal proximal tubule phosphate reuptake. Histologically, you'll see bland spindled to stellate cells that produce unusual, these hyalinized, smudgy, grungy, dirty calcifications. And you can see the FGF23 either by testing blood or by IHC. Clear cell sarcoma of soft tissue, or aka malignant melanoma of soft parts. These are malignant, typically in your young adults. It's characteristic nested growth with dividing collagenous bands, as you can see here. And cytologically, you'll see epithelioid, mostly to spindled cells, with palely eosinophilic to amphiphilic cytoplasm. You'll have vesicular nuclei and prominent nucleoli. and scattered multinucleate giant cells. So despite its name, it not necessarily can be clear. And it does express melanocytic markers like S100, HMB45, MIT-F, and molecularly defined by EWSR1 ATF1 fusion. Extraskeletal myxoid chondrosarcoma. So this is malignant, but although there's prolonged survival, there's frequent metastases. And despite the name, there's no overt cartilaginous differentiation. You have an abundant myxoid matrix with cords, clusters, networks, and nests of cells with modest amounts of eosinophilic cytoplasm and round oval nuclei. And this is called an ATNT tumor because it reaches out and touches someone. So cells are often reaching out to touch each other. And molecularly defined by NR483 fusion, often with EWSR1 or TAF15. FAT. Not that kind of fat, FAT, but fat, PHAT. Pleomorphic hyalinizing angiectatic tumor / on a spectrum, hemosiderotic fibrolipomatous tumor. These are malignant, usually adults in soft tissue, oftentimes on the foot. So let's talk about fat first. Pleomorphic hyalinizing angiectatic tumors have histologically on low power, prominent thin-walled ectatic blood vessels lined by fibrin. As you look higher power, you'll see within it, you'll see spindle to pleomorphic cells with intranuclear inclusions and fine hemosiderin granules. So look at these thin-walled ectatic blood vessels lined by fibrin, and then you'll have the spindle to pleomorphic cells. And then hemosiderotic fibrolipomatous tumor is thought to represent early fat. It can occur by itself or at the periphery of fat. And histologically, you'll see adipocytes with admixed hemosiderin-laden spindle cells, hemosiderin-laden macrophages, and scattered inflammation. And it will be CD34 positive. And both have recurrent TGF-BR3 and or MGEA5 rearrangements. Synovial sarcoma, these are malignant, usually young adults, often soft tissue, but also common in the thorax and head and neck. You can have two types, monophasic synovial sarcoma, just the spindled component, and a biphasic synovial sarcoma, where you have spindled and epithelioid components. And these are fairly uniform spindled cells with relatively little cytoplasm. You can see your staghorn vessels, and you'll see epithelial cells arranged in nests and glands with paler cytoplasm and vesicular nuclei for your biphasic synovial sarcoma. IHC, it'll have patchy EMA and CK, usually CD99 positive and TLE1 positive. Molecularly, it's defined by a TX18, SS18, SSX gene fusion. Epithelioid sarcoma, this is malignant, often in youngish adults. There's two types, classical conventional type. These are cellular nodules of epithelioid to spindle cells with a central degeneration necrosis. Looks vaguely granulomatous, and you'll have vesicular chromatin and eosinophilic cytoplasm. So if you have like a soft tissue tumor and it looks kind of granulomatous, you want your differential to be epithelioid sarcoma because these are malignant. You don't want to miss these. And then you have your proximal type, which have multinodular and sheet-like growth of these large pleomorphic cells with these large vesicular nuclei and prominent nucleoli. And it often has a rhabdoid appearance. IHC-wise, it'll have an INI1 loss. Cytokeratin / EMA and CD34 will be positive. Molecularly, it's complex, but it has that SMARCB1 INI deletion. Alveolar soft part sarcoma. These are malignant, often young adults. It has this organoid, hence alveolar, nest of large uniform epithelioid cells with abundant eosinophilic granular cytoplasm. You'll have these round nuclei with prominent nucleoli, and PAS demonstrates rhomboid or rod-shaped intracytoplasmic inclusions. This is positive for TFE3, S100, and Desmond minus less so than often. Molecularly, it's defined by an ASPS-CR1 TFE3 fusion. Of note, ASPS of the ASPS-CR1 stands for alveolar soft part sarcoma, and it's important to not get confused with alveolar soft part sarcoma is positive for TFE3, and synovial sarc is positive for TLE1. Don't be like me, where I got confused with that. Ewing sarcoma. This is malignant, variable neuroectodermal differentiation. Often arises in the bone of young kids, but it can be extraskeletal. And if it's in the chest wall, it's known as an Askin tumor. This is part of your small round blue cell differential. It has a lobular growth pattern. And if you see these pseudo-rosettes, that can kind of cue you in that it might be Ewing sarcoma. To help you out, IHC, you can get a CD99 and it'll be diffuse membranous. And the cytoplasmic glycogen stains with PAS, and molecularly it'll have a EWSR1 fusion, more commonly with Fly1, but it can also be with ERG. The Fly1 EWSR fusion is T1122. Chick rearranged sarcomas. These are malignant and more aggressive than Ewing's. It's often in young adults in soft tissue. It's also part of your small round blue cell differential. You'll have scant eosinophilic to clear cytoplasm in these small round cells, and geographic necrosis is usually present. IHC-wise, it'll be positive for the WT1 positive and variable CD99. And molecularly, you'll have your Chick's DUX4 fusion. B-core rearranged sarcomas. This is malignant, and the outcome is similar to Ewing, so a little bit better than your Chick sarcoma, Chick rearranged sarcomas. Often in the bone or soft tissue of the young. Architecturally, you'll have solid proliferation of mostly small round cells. And then cytologically, you'll see monomorphic round nuclei, fine chromatin, and delicate capillary networks, as you can see here. And sometimes it can be partially spindled, and molecularly has a B-core fusion with either CCNB3 or mammal L3, or a B-core internal tandem duplication. IHC will be SATB2 positive. Solitary fibrous tumor. The old name is hemangiopericytoma. It's usually benign, although it can be malignant. And if it is malignant, you'll have factors associated with malignancy will be numerous mites, oftentimes greater than 4 per 10 high power field, large size, especially if it's greater than 15 centimeters, and tumor necrosis. You'll see this in adults in deep soft tissue or serosal surfaces, classically the lung or pleura. And you'll have this patternless pattern of varying cellularity of bland spindle cells with varying amounts of collagenized stroma. You'll have prominent staghorn vessels. It can be hyalinized or myxoid. It'll be positive for STAT6, also CD34 and CD99 positive, but variable. And molecularly, you'll have this NAP2 STAT6 gene fusion. All right, we are almost there. Congrats if you've been with me throughout. Okay, intimal sarcoma. This is malignant, arises in large blood vessels of systemic and pulmonary circulation, characteristic predominantly intraluminal growth with obstruction of blood flow and seeding tumor emboli. You'll have mild to severely pleomorphic spindled cells with necrosis, nuclear pleomorphism, and mites. And you can have this myxoid or fascicular areas. IHC, it'll be MDM2 positive. And molecularly, you'll have this amplification of MDM2 CDK4, just like in your atypical lipomatous tumor or well-differentiated liposarcoma. An undifferentiated sarcoma. This is a sarcoma with no identifiable line of differentiation. Remember, we talked about our pleomorphic liposarcoma? We can see those this line of adipocytic differentiation. That's why it's called a pleomorphic liposarcoma. But undifferentiated, you don't see any line of differentiation. You shouldn't see any rhabdoid kind of appearance. And it's a diagnosis of exclusion, and we subclassify based on histologic appearance. So you have your undifferentiated pleomorphic sarcoma, you have your undifferentiated spindle cell sarcoma, undifferentiated round cell sarcoma, and undifferentiated epithelioid sarcoma. Wow, we made it through. Thanks for following with me. And then last thing, we grade tumors based on the French grading system, the FNCLCC, based on tumor differentiation. And the higher the score, the more de-differentiated it is, or immature it is. And based on what it is, already predetermined to score for you. Mitotic count, you have your score 1 to 3, and tumor necrosis, if it's greater than 50% necrosis, that's score 2. So the higher the grade, the worse the prognosis. And it's important to note some tumors are not graded, like your GIST, alveolar and breinal rhabdomyosarcoma, MPNST, angiosarcoma, extraskeletal myxoid, chondrosarc, clear cell sarcoma, ASPS, and epithelioid sarcoma. Well, again, thank you so much for watching this video. Thank you to Dr. Schaberg for preparing this marvelous compilation of soft tissue tumors. And you know, repetition is the key to adult learning, right? So come on, let's do it. So soft tissue tumors, adipocytic, you have your lipomas, you have certain subtypes. Atypical lipomatous tumor in the extremities, well-differentiated liposarcoma in the retroperitoneum. They both look the same. You have your lipoblasts. And if you're unsure, get your FISH for MDM2 amplification. Dedifferentiated liposarcoma, it also has that MDM2 FISH. Myxoid liposarcoma, usually younger, you'll have this myxoid matrix, chicken wire vasculature, and if it loses the myxoid component, you want to think about higher grade myxoid liposarcoma. Defined by a 1216 FUS-DDIT3 fusion. Pleomorphic liposarcoma, it's like an undifferentiated pleomorphic sarcoma, but it has the scattered lipoblast and a line of differentiation. Fibroblastic, myofibroblastic tumors, nodular fasciitis, defined by USP6 gene fusion, tissue culture-like, rapidly growing. Proliferative fasciitis, like your nodular fasciitis, but you'll have these basophilic ganglion-like cells. Ischemic fasciitis, reactive proliferation on the bony prominences of elderly and or immobile patients. Elastofibroma, elastin stain will show, or EVG stain will show degenerative beaded appearance under the scapula of elderly patients. Nuchal type fibroma, posterior neck of adults, almost acellular, densely collagenized. Gardner-associated fibroma looks similar to nuchal type fibroma in younger patients. Strong association with FAP and desmoid tumors. Fibrous hamartoma of infancy during the first 2 years of life. Organoid growth pattern, triphasic, you'll see intersecting bands of mature fibrous tissue, nests of immature round ovoid or spindle cells, and then interspersed mature fat. Fibroma of tendon sheath grows on the tendon sheath or aponeurosis, usually adults, mostly hypocellular with spindle cells and cleft-like spaces. Calcifying aponeurotic fibroma, primarily in children, can reoccur, grows into aponeurosis, tendons, or fascia. You'll have distinct areas of calcification and cartilage. Fibromatosis, you can have your superficial and deep desmoid type, infiltrating growth, broad sweeping fascicles, positive margins does not predict recurrence. IC nuclear beta catenin. IMT, inflammatory myofibroblastic tumor, borderline malignancy, bland spindle to stellate cells. Look for your prominent lymphoplasmacytic infiltrate. Around half have the ALK gene rearrangement. Fibrosarcoma, diagnosis of exclusion. Remember, DFSP can have a fibrosarcomatous transformation, and you'll have that herringbone pattern. Infantile fibrosarcoma, rapidly growing in newborns or infants. Tightly packed spindle cells with herringbone appearance, often lymphocytic infiltrate. Molecularly, you'll have an ETV6 and TREC3. Myxofibrosarcoma, these are oftentimes seen in elderly. There is no specific molecular to help diagnose these. You'll see these curvilinear vessels with tumor cells attached like melting wax. Myxoid background. Low-grade fibromyxoid sarcoma, in contrast, is in younger to middle-aged adults. You'll have more fibrous components than your myxoid. They also can have curvilinear, but it's MUC4 positive and has a FUS-CREB3L2 fusion. Sclerosing epithelioid fibrosarcoma, often along the same lines of your low-grade fibromyxoid sarcoma. Densely hyalinized stroma with epithelioid cells, IHC positive for MUC4. Nerve sheath tumors, schwannoma, Antoni A, hypercellular, Antoni B, myxoid, hypocellular. Your Verrucate bodies are in Antoni A. You can have ancient change, which look atypical but should have no mites, and you can have exclusively Antoni A schwannoma and melanocytic schwannoma. Neurofibroma, multiple neurofibromas, hallmark of NF1. If you have plexiform neurofibroma, like your bag of worms, almost exclusively in NF1. randomly oriented spindle cells with shredded carrot collagen diffuse S100, but less so than schwannoma. Perineurioma will be perivascular whorls, long, thin, delicate bipolar processes, positive for EMA, Claudin-1, and GLUT1. Granular cell tumor, positive for S100, CD68, looks abundant eosinophilic granular cytoplasm, highlighted by PASD. Ganglioneuroma, no immature neuroblastic elements, mature ganglion cells, and neuromatous stroma. Traumatic amputation neuroma, haphazard proliferation of nerve fascicles, damaged nerve often easily identified. MPNST, often in NF1, must arise from a peripheral nerve or pre-existing peripheral nerve sheath tumor. Patchy S100 SOX10, you can have loss of H3K27ME3, although it's not necessarily specific. Trident tumor is with MPNST with rhabdomyoblastic differentiation. Other nerve sheath tumors include nerve sheath myxoma, ectopic meningioma, palisaded encapsulated neuroma. Perivascular tumors, glomus tumors, copy-paste cells, can be painful. Myopericytoma, myofibroma, on a spectrum, myofibroma, head and neck, first year of life, biphasic, immature plump spindle cells with staghorn vessels and areas of mature spindle cells in bundles and whorls. Myopericytoma, superficial mass in adults, nodular, well circumscribed. Perivascular epithelioid cell tumor, express melanocytic and smooth muscle markers. A subset are associated with tuberous sclerosis, and they include angiomyolipoma, clear cell sugar tumor, and lymphangioliomyomatosis. Smooth muscle, you can have leiomyomas, you can have pilar leiomyoma, angioleiomyoma, you have your leiomyosarcomas, often notable pleomorphism and often atypical mites. EBV associated smooth muscle tumor seen in setting of immunodeficiency, and you'll see tumor infiltrating lymphs in the background of smooth muscle tumor, and you need an EBV to confirm. Skeletal muscle tumor, equivalent to your leiomyoma of the skeletal muscle, is your rhabdomyoma. Cardiac type rhabdomyoma will have your spider cells associated with tuberous sclerosis. Adult type rhabdomyoma, usually head and neck, pharynx or tongue. Fetal type rhabdomyoma, usually head and neck, any age. Embryonal rhabdomyosarcoma resembles embryonic skeletal muscle cells, positive for MyoD1, myogenin. You have rhabdoid cells and strap cells. Botryoid type will have the cambium layer. You'll have this epithelium, hypocellular area, and then you'll have this densely cellular layer. Alveolar rhabdomyosarcoma, more aggressive than embryonal if you have that characteristic FOXO1 fusion with either PAX3 or FAX7. Strong diffuse myogenin, small round blue cell, doesn't have the strap cells or tadpole cells. Pleomorphic rhabdomyosarcoma, malignant adults, deep soft tissue. Spindle cell rhabdomyosarcoma, likely a variant of embryonal, young boys, paratesticular. Sclerosing rhabdomyosarcoma, usually adults in soft tissue, small round blue cells, nest in single file. MyoD1 strongly positive. Fibrohistiocytic tumors, tenosynovial giant cell tumor. You can have your localized type, diffuse type, fibrous histiocytoma in Dermland. You have your DF. Remember, it looks more heterologous than your DFSP, which is monomorphic, more so. You can have your plexiform fibrohistiocytic tumor and deep benign fibrous histiocytoma. Vascular tumors, vascular malformations, AV malformations, venous malformation, which includes your cavernous hemangiomas, cutaneous capillovenous malformations like your telangiectasias, and intramuscular hemangioma. Mason's tumor, papillary endothelial hyperplasia, it's recanalization of a fibrin thrombi in the vessel. Bacillary angiomatosis caused by Bartonella in immunocompromised patients have a neutrophilic infiltrate, get your Werthin starry. Hemangiomas, you have your pyogenic granuloma or lobular capillary hemangioma. Infantile juvenile hemangioma, get your GLUT1. You can have hobnail, anastomosing, and spindle cell hemangioma. Epithelioid hemangioma, the endothelial cells are really plump, and you have background inflammatory eosinophils. Lymphangioma, Kaposiform hemangioendothelioma associated with Kassel-Bach-Merritt, exclusively in children, have both features of capillary hemangiomas and Kaposi sarcoma. Epithelioid hemangioendothelioma, look for your blister cells. CAMTA1 is specific, and Campto-1 WWTR1 molecular fusion. Kaposi sarcoma caused by HHV8. Your differentials include angiosarcoma. Pseudomyogenic hemangioendothelioma looks like a rhabdomyoblast, hence the name, defined by SERPIN1 FOSB gene, often in the young men on the leg. Atypical vascular lesion, often irradiated skin of breast, no MYC overexpression. Angiosarcoma, very aggressive. If it's in post-radiation angiosarcoma, you have a high MYC amplification. Tumors of uncertain differentiation. Myxoma, if it's intramuscular, think about Mazebrod syndrome. Deep angiomyxoma, it's benign, adult women in pelvico-perineal regions. Extrarenal rhabdoid tumor, very aggressive, has that SMARCB1 INI loss and characteristic rhabdoid cells. Ossifying fibromyxoid tumors, peripheral zones of metaplastic bone with monomorphous round to spindle cells, S100 positive. Angiomatoid fibroshistiocytoma, thick fibrous capsule, cuffing of lymphocytes, pseudoangiomatoid spaces full of blood. EWSR1 CREB1 fusion, ectopic hematomatous thymoma. No evidence of dymic origin differentiation. You'll have haphazard blending of spindle cells, epithelial islands, and adipocytes. Phosphoteric mesenchymal tumor produces FGF23. You can have tumor-induced osteomalacia, grungy, flocculent calcifications. Clear cell sarcoma of soft tissue, aka malignant melanoma soft parts, not necessarily clear sometimes, can have that amphiphilic cytoplasm, expresses melanocytic markers, and molecularly is EWSR1 ATF1. Extraskeletal myxoid chondrosarcoma, no overt cartilaginous differentiation, has this abundant myxoid matrix, an AT&T tumor where the cells are reaching out and touching each other. Defined by, has the NR4A3 fusion, often with EWSR1 or TAF15. Fat, pleomorphic hyalinizing angiocytic tumor or hemosiderid, on the spectrum with hemosiderotic fibrolipomatous tumor. You have this prominent thin-walled blood vessels with fibrin, and you'll have spindled pleomorphic cells with intranuclear inclusions and fine hemosiderin granules. And then hemosiderotic fibrolipomatous tumor is thought to represent early fat. Synovial sarcoma, monophasic, biphasic, usually young adults, often in the thorax and head and neck, has an X18 fusion. Epithelioid sarcoma, classic conventional type, looks vaguely granulomatous. Proximal type has this rhabdoid appearing cells, and it has that INI loss. Alveolar soft part sarcoma, TFE3 positive, organoid nest of large uniform epithelioid cells with abundant eosinophilic granular cytoplasm. Ewing sarcoma has that strong membranous CD99 staining and EWSR1 fusion, oftentimes with Fly1, or it can be with ERG. Chick rearranged sarcomas, more aggressive than Ewing's, WT1 positive, variable CD99, small round blue cell tumor, and can have geographic necrosis. And it has that Chick DUX4 fusion. B-core rearranged sarcomas, outcome similar to Ewing's, often in bone or soft tissue of young, solid proliferation of mostly small round cells. Can have B-core fusion with either CCNB3 or mammal L3. IHC is SATB2. SFT, usually benign, has that staghorn vessels with patternless pattern, STAT6 positive, and molecularly NAB2 STAT6 gene fusion. Can be malignant. Intimal sarcoma arises in large blood vessels of systemic and pulmonary circulation, characteristically predominantly intraluminal growth, mild to severely pleomorphic spindled cells, MDM2 positive, and has amplification of MDM2 CDK4, like an atypical lipomatous tumor, a well-differentiated liposarc. Undifferentiated sarcoma, it's a diagnosis of exclusion and should not have identifiable line of differentiation. You can have your subtypes: undifferentiated pleomorphic sarcoma, undifferentiated spindle cell sarcoma, undifferentiated round cell sarcoma, undifferentiated epithelioid sarcoma. And here is your pattern-based approach, but I'll just leave this here for your own review. And last of all, thank you to Dr. Schaberg for these excellent notes, and thank you to you for going through all of this. All right, see you next time in Pathagonia.